a challenge to dignity. Our goal was to link academics, activists, and agencies concerned with the health of refugees and asylum seekers in a spirit of collaboration and comparison, bringing together professionals working with different populations of forcibly displaced peoples, ethnic groups, and nations. The video you are watching will contain an individual presentation edited to stand alone. We hope you find them to be of value.
Our next speaker is Dr. Lillian Walkover, who is a critical global health scholar jointly appointed in the Department of Communication and in the Global Health Program here at UC San Diego. Her talk is entitled Pathways Toward Medical Licensure for Refugee and Asylee International Medical Graduates Living in the United States. So let's just make sure.
Okay. Thank you so much for that introduction. Today I'm presenting a paper written with Susan Bell. A longer version of this paper is currently under review. Thanks so much to the conference organizers for bringing together these important conversations and for including our work. Today I'm going to talk about healthcare providers who are also themselves refugees and asylees. So the American Association of Medical Colleges estimates that the US experienced a shortage of more than 20,000 physicians in 2017 and predicts that this will grow to a shortage of between 42,000 and 121,000 physicians by 2032. As we know, during the coronavirus pandemic, the need for physicians has become so acute that governors and health officials have called on retired physicians to return to work. Many states loosened licensing restrictions and waived licensing fees, and the Federation of State Medical Boards gave free access to its database to streamline the verification process. These efforts have targeted a range of physician populations, including both retired and student physicians, as well as international medical graduates, the population I'll be talking about today. So international medical graduates, or IMGs, makes up approximately 1/4 of all practicing physicians in the US, and thus are key resources in addressing shortages. IMGs tend to practice in underserved areas and to take care of more minority, Medicare, and Medicaid patients than US medical graduates. In addition, they have the potential to provide culturally and linguistically competent care for an increasingly diverse patient population. In US social science scholarship, IMGs are divided into US citizen IMGs, US IMGs, and non-US citizen IMGs, or non-US IMGs. For the purposes of US medical licensure qualifications and record keeping, US and non-US IMGs are lumped together. However, these categories are too blunt to demonstrate important differences among non-US IMGs. In the larger project of which today's talk is a part, we propose a new category of international medical graduates who are forced to leave their home countries, a group we refer to as refugee physicians. We use the term refugee physicians for 3 reasons. First, the term refugee physician focuses attention on how physicians are located among forcibly displaced people worldwide, including their distinct relationships to their home countries, countries in which some of them seek sanctuary before arriving in the US, and the US, where some of them requested asylum and others have been resettled. Second, because refugee is an umbrella term that blends categories of law, policy, social science, and everyday usage, it encompasses a wide variety of lived experiences along a continuum of compulsion to leave. Finally, refugee physician illuminates the group's distinct relationship to medical licensure and brings into focus structural barriers that impede their goal of attaining a US medical license. The piece we're sharing today focuses on a scoping review of nonprofit physician career assistance programs serving this population. In this presentation, I share the results of the review, including updates on how programs have been affected by the ongoing pandemic. So, to practice medicine in the US, all IMGs must obtain a US medical license. Their education must be certified by the Educational Commission on Foreign Medical Graduates, and they must pass the USMLE, the US Medical Licensing Exam, and complete a residency before applying for a license to practice. Here I want to note that recent changes in the USMLE, some of which were already under consideration, were catalyzed by the pandemic. These include the shift of the Step 1 exam to a pass-fail grade and the elimination of the Step 2 clinical skills exam, which is in turn related to the development of a set of pathways for ECFMG certification that combine different options for proving educational and clinical preparedness for beginning a medical residency in the US. So, this process of becoming a licensed physician in the US, including ECFMG certification and completion of a US medical residency, is the same for everyone who attends medical school outside of the US and Canada, no matter how much experience they may have had before arriving. Even again, if they've already, for example, completed a residency and practiced for 10 years in a variety of intense settings. Many non-US IMGs come to the US to pursue graduate medical education, but others enter the US for other reasons, after the completion of medical school and at different stages of their careers. In our study, more than 2/3 of the physician participants fled their home country because of violence, imprisonment, threats to safety caused by political or religious beliefs, or to avoid an unstable political climate. For these refugee physicians and other IMGs, gaining admission to a US residency is a key bottleneck in the process of gaining a US medical license. Of course, there are no formal regulations that require residency programs to favor US medical graduates, but graduates of US medical schools are more likely to be accepted in a residency. Even if non-US IMGs pass the required exams for entrance and become certified by the ECFMG, about half of them fail to match to a residency position each year. Key determinants include preparation for the USMLE, English proficiency, financial constraints, ability to study full-time for an extended period, specialty, and number of years since graduation from medical school. Matching requires strong social networks, notably US physicians who can write letters of recommendation, typically based on an applicant's performance in a US clinical setting. This pathway for IMGs to medical licensure in the US is time-intensive and costly and requires time, money, and social networks. So, during the past 20 years, a patchwork of programs has been established to support US medical licensure for non-US IMGs and US trained physicians who have left the workforce and want to re-enter medical practice. We identified 15 nonprofit programs that have helped over 5,000 physicians pursuing a variety of career options, including supporting at least 273 non-US IMGs gain admission to a medical residency program in the US. Each of these programs included in the review offer a combination of services, educational guidance, courses, and clinical experience. The review excludes for-profit companies because they're usually prohibitively expensive. So to develop this review, we first searched with the keyword physician reentry in Google, and with this keyword, we identified individual programs as well as 4 databases: the Federation of State Medical Boards Directory of Physician Assessment and Remedial Education Programs, the Physician Reentry into the Workforce Project, the American Medical Association's Observership Program listings for international medical graduates, and the Imprint Program Map. Website review and email outreach to the identified programs and databases yielded a list of 16 programs that offer services available to non-US IMGs seeking US medical licensure. One of the IMG-specific programs, the Welcome Back Initiative, is an umbrella organization with at least 8 Welcome Back centers that serve physicians at the time of the original search. While the initial analysis for this paper was conducted in 2018, in 2021, we reviewed each of the listed programs to see how they have been impacted by the ongoing COVID-19 pandemic and updated the list. Overall, non-clinical, as you'd expect, educational and mentorship services have been moved to remote services, remote formats, and 2 Welcome Back centers no longer qualified for inclusion. One shifted away from serving physicians and another closed. One new organization was in the process of being founded during the initial study period and has been added to the list. This brings the current total to 15 programs. In addition to reviewing the range and status of programs, we also checked for updated numbers reflecting the impact of each program's work. However, no updated statistics on the number of physicians served were available, presumably because of the pandemic. So, all of the programs are nonprofit and all provide some type of support towards certification by the Educational Commission on Foreign Medical Graduates and admission to a medical residency. Many of the programs provide services to IMGs in a geographical area within one state, while others have chapters across the US. The review shows that in many areas of the US, direct services for this population are not available. The organization with the broadest geographic reach is the Welcome Back Initiative, an umbrella organization founded in 2001 by Jose Ramon Fernandez Peña, an immigrant physician who faced barriers to practicing in the US and is currently the president of the American Public Health Association. The Welcome Back Initiative runs Welcome Back centers in partnership with local organizations. Each Welcome Back center works with a community college or regional health center where educational case managers provide assessment, guidance, and access to education for immigrants from a variety of health professions. WBCs have served approximately 15,000 internationally trained health workers from 167 countries. 1/3 of these internationally trained health workers are physicians, and 128 physicians served by Welcome Back centers have been accepted into residency programs. At the time of the updated review, we identified 5 Welcome Back centers that provide services to physicians. So, there are 2 programs in California and Minnesota that provide support for clinical training, which, as we've discussed, is a crucial step to US licensure. One is hosted nearby at UCLA and enrolls IMGs willing to commit to a family medicine residency program in California that serves an under-resourced community. To qualify, students must have finished medical school or residency in another country within the last 5 years and be bilingual and biculturally competent in US American and Latin American cultures. The program supports participants during the process of testing, certification, and application to these residency programs. The Minnesota program, which has the same name, but is distinct, was founded by a physician from Liberia who faced barriers to US medical licensure and seeks to relieve the primary healthcare shortage in Minnesota. It provides career guidance, financial support, and residency preparation. As of 2018, the program had a database of 150 non-US IMGs. 130 of these physicians were actively pursuing a residency, and 20 had been accepted into a residency program. In addition to these sort of larger programs, 3 smaller scale programs focus on educational case management and connect non-US IMGs to language and other courses. The White Tulip Health Foundation is an association of health professionals with 24 different chapters that provide mentoring, career guidance, and workshops on healthcare topics. GT Docs, or Global Talent Doctors, which is part of a regional initiative in Idaho and Utah to support immigrants, provides customized plans for individual medical professionals and peer support for USMLE preparation. The Washington Academy for International Medical Graduates was developed by a group of IMGs in Washington State who had been engaged in policy advocacy and provides a range of mentorship and career guidance. The Academy is also working on providing links to research and clinical experience. Zooming out a little bit, there are 3 other programs in the review that target a broad population interested in re-entry to clinical work and provide resources that are also useful to non-US IMGs living in the US, such as clinical experience and online education and self-study resources. The Drexel Medicine Physician Refresher and Re-Entry Program provides online clinical skills courses and clinical preceptorships for US educated physicians returning to clinical work and IMGs. CPEP's Return to Clinical Practice Program and Texas A&M's K-Star Physician Resources provide programs that are open to non-US IMGs, but do not target this population. One sort of additional keynote on these kind of programs, observerships have the potential to improve an IMG's chances of getting into a US residency program by providing opportunities to observe medical practice in a US clinical setting, connect with a social network of insiders, and identify physician mentors to write those crucial letters of recommendation. According to American Medical Association guidelines, the completion of an observership should not be considered a required step on the path to a residency program. However, 90% of non-US IMGs complete some type of US-based clinical experience before successfully matching to a residency. So it's basically an implied requirement that's not stated. The review identified 7 programs that provide access to experience in US medical settings, including links to observership programs, residency preparation programs, clinical rotations, preceptorships, and other forms of supervised clinical experience. However, many observerships are expensive and run by for-profit companies and can cost as much as $5,000 per month. Here's an example of one for-profit company that has received over $1 million in venture capital funding. So, the small number of programs identified by this review have had modest but important successes in providing career assistance services to more than 270 non-US IMGs that have matched to residency programs. But they are out of reach for many refugee physicians and other non-US IMGs living in the US. As a whole, the nonprofit career assistance programs identified by the review are providing educational guidance, English courses focused on technical language skills, access to observerships or other forms of clinical experience, and crucially, financial support for the cost of certification, licensing exams, and application to residency, all of which can add up very quickly. However, no one program provides all of these services. So additional research is needed to assess the effectiveness of these programs and to prioritize the importance of the different services they offer. A large-scale study of the effectiveness rates of the 15 programs, including follow-up with non-US IMGs who achieve US medical licenses, would help to inform expansion of these types of services to the many states where no support is currently available. Of course, qualitative research can shed light on the experiences of individual physicians on the pathway and service providers assisting them. In our current study, based on in-depth interviews with service providers and refugee physicians, we are identifying what led some non-US IMGs to successfully match in residency programs and others to be unsuccessful. The first paper from the larger study, The Case for Refugee Physicians, Forced Migration of International Medical Graduates in the 21st Century, was published this spring. However, only some of the physicians in the larger study were supported by one of the 15 programs described today. So these programs are emerging, and their evolution will be important to understand in light of efforts in medicine to increase the number of physicians in the US and to foster the development of diverse, culturally competent physicians in a changing and mobile global environment. This review represents an important step in that direction. In addition, each of these dynamics have been impacted by the intersecting forces of the pandemic and the urgent need for clinical care, as well as ongoing forced migration around the world. In the larger project, we make visible the potential contributions of refugee physicians to the country in which they now live. When these physicians can gain US medical licenses and practice the skills they have worked hard to learn in a career that they love, the US gains needed physicians who have strong clinical expertise. In addition, these physicians bring linguistic and cultural competencies in which the US healthcare system is clearly deficient, often paired with experience and willingness to work in under-resourced settings. As we face unprecedented burdens on our healthcare system, it has become increasingly urgent to make visible both the category of refugee physicians and the contributions they stand to make when they are able to practice medicine, and to provide pathways and resources to help make this possible. In closing, we are grateful to the organizations that work in this field, helped us recruit refugee physicians for the larger study, and participated in interviews about providing support for IMGs. Thanks as well to our undergraduate research assistants at Drexel University. I look forward to your questions.
Thank you, Lillian. Questions from the audience in the room first?
I have a question. Yeah. So looking at the list of organizations that were creating programs, they seem to be university-based, maybe tied to medical schools. I'm interested in the role potentially of other kind of American professional organizations. Were there any structural barriers to, opening up new pathways to licensure? Like, do they feel a threat were there other sort of structural forces sort of mitigating against expansion that you found, or do you anticipate that that's potentially a problem?
Yeah, so the only one of these connected to a medical school is the UCLA program. Everything else, it's very strongly sort of coming out of community-based organizations. The support that is there is strongly coming out of community-based organizations and sort of refugee and immigrant serving organizations, as well as organizations of immigrants and refugees from particular communities. But yes, I mean, has been a very strong history of US protectionism of US medical graduates, which is part of why we have the shortage in the first place, right? So part of all these dynamics is it the 1996 or 1997 cap on funding for residency programs, which was partly put in place, with support by the American Medical Association, sort of to stem the tide of international medical graduates coming into the United States. And it's a case of sort of the American doctors did too good a job of protecting their position, and now there's not enough doctors in the United States. And yet we're still drawing on these populations from around the world. So there is this really interesting, and now, American physician organizations are starting to support sort of reopening or some kind of expansion of funding, sort of going back against the initial sort of stops that they put in place. So yes, there's a lot of protectionism. And then there's also sort of a bifurcated, even when you do get into residency programs, a great book came out last year or the year before. The pandemic sort of messes up time, but sometime recently, Tanya Jenkins, about sort of the different kind of residency programs that people are trapped into and the different kinds of education that you get in residency programs that are primarily recruiting US medical graduates versus international medical graduates. Yeah.
Hi, this was really interesting. My question is whether this problem exists in Europe and other countries, for instance, in England and in Germany and everywhere else. So were you able to have a global view of what other countries are doing specific? Because as with doctors and lawyers, your particular qualification matters and is certified by the country. Yeah. But even if you move from one country to the other, you may have language, etc. So of course compounded for refugee populations. Yeah. But what happens elsewhere?
Yeah, so I think like many things between the US and Europe, it looks so much better in Europe. And then of course, once you're actually in Europe, there's still a lot of bifurcation and issues. And so, for some participants in our study, their relatives were more able to practice medicine or more quickly able to practice medicine in other countries than in the US. That doesn't mean they didn't face significant barriers. So there's similar sort of structures of having to relicense, but I'm trying to remember, certainly Germany and the UK, but most countries have put in place sort of different levels of these question of sort of how do you assess somebody's education, their licensure, and make sure they have some amount of clinical experience in the country in which you're then granting them a license. I'm forgetting the exact process in the UK, but it is both significant and easier than the US process. You don't have to fully repeat your residency, basically, because again, sort of in the US, the deal is doesn't matter how long you practice, you're basically competing with fourth year US medical students to get into a residency. And that's the position. You're sort of knocked back to the fourth year of medical school, but you're actually sort of ranked below a bunch of those students. And so most other countries have at least some structure that allows people to sort of take exams or otherwise sort of be evaluated to figure out where they actually are in relation to being ready to practice medicine in that country. And then in some countries will actually accept medical licenses. So for example, like an Iraqi physician can practice in Jordan, but won't be eligible for citizenship in Jordan because of the politics of, sort of the international refugee regime. It's a great question. And the short answer is everybody else does it better than we do, but there's still huge barriers in other countries. So for example, that woman, one of her siblings, she's still not a physician in the US, is very frustrated by that. And she has a sibling, I believe, who is a practicing physician in the UK and another one who's a practicing physician in Jordan. So they did face barriers, but were able to achieve those goals in a way that she has not.
Thank you.
Yeah.
Well, I was curious if you see that these foreign medical graduates are going through a lot of debt to try to kind of achieve that goal here in the US, and then how that plays out.
Yeah, absolutely. I mean, a lot of them are in a position, I think, to sort of borrow like structurally. So they're mostly borrowing from family. And I would say the people who are even able to pursue this at all are able to pursue it because their parents are effectively giving them or lending them $10,000 to $20,000. And it's because their family has that as a gift, effectively. They're mostly they're not taking out loans that we saw. Mostly they're only able to even try because there's some significant, amount of sort of family financial flexibility that they're able to draw on. No, those aren't true. Some of them do max out credit cards and take out. The processing is incredibly expensive, as anyone who's ever applied to residency. I mean, even just these exams are thousands of dollars to take. And then, of course, as many of you guys know, we're physicians to go through this process of interviewing. You have to pay for flights and meals and hotels. And, the whole process is based on an idea that you are a upper middle class, fourth year medical student who is basically not paying any of your own expenses and has no responsibilities, right? No sort of childcare. Most of the physicians, I think all the physicians who matched were in our study were men from the Middle East, and most of the physicians who had applied but had not matched were women. And you can see, the impact of caregiving on, time to study. And people were taking care of their children and doing a job and applying to medical residency, but because of the sort of extra time that puts in, the impact on your scores, if you can't study for as many hours, you can see in the end that their rate of matching is lower. Yeah.
Hi, first, thank you so much for the work that you're doing. I'm an IMG myself and a daughter of refugees from Jordan. So I worked with refugee physicians in Jordan, and I know how much of an asset they are to the country.
Absolutely.
So this work can really be transformative to the way we do healthcare in this country here in the United States. My question to you, have you thought of taking this to the policy level, to the next level, and interviewing those who could act like roadblocks, such as people at the AMA, the American Medical Association? Could that be the next step for your research?
Yeah, absolutely. So one caveat is that this was my postdoc project, so it's really Susan Bell's, conception and sort of her choice what happens with it, and is continuing to do great stuff with it. We still have a lot, honestly, even from this that we just published the paper looking at the physicians, but we haven't even published anything about the service providers we did talk to. But yes, I do think that would be incredibly valuable. I think interviewing, personally, one study I would really like to do, and people have done informal versions of this, but interview the residency directors, the residency program directors, because they're responding to all these forces impacting on them, but they're really these incredible gatekeepers in this process. Obviously, the federal funding and I don't know why I can't remember if it's 96 or 97 funding cap on reimbursement, basically, for residency positions is a huge issue. But yeah, I think that interviewing them is really key. And honestly, a lot of, we think of these systems like the match, if you go to the US Medical Residency Match website, they're like 2 Nobel Prizes have been won for this algorithm, which makes you think that it's this impersonal algorithm. But so many of the people who did match in these cases, it's because somebody knew somebody who talked to the program director and said, I know you would otherwise throw out this file, but look at it. And the most horrific one, and I won't tell you who this happened to for their anonymity, but I mean, we did have somebody who basically was admitted to a program, and they basically told her, like, if you donate the cost of your medical residency to us, which is always estimated at about $200,000 to train a medical resident. So if you, statutory refugee, will just donate $200,000 to our institution, we'll let you in. So, we pretend that these things are this medicine is above all of these things, but medicine is full of humans who make human decisions, including corrupt ones. And so, yeah, absolutely. I think the residency program directors would be a really interesting group to intervene on and to sort of interview, but certainly the policymakers. And there are efforts. I mean, Jose Fernandez Peña, is a huge figure in this field. Obviously, he's now running the APHA. has helped submit multiple pieces of legislation, and there are ongoing efforts at high levels, at state levels, and at national levels to change some of these pieces. So yeah, I think there are very clear policy implications. This was a qualitative sociological study, so it wasn't meant to inform policy, but certainly, hopefully, to inform people who are informing policy. So absolutely. Thank you for bringing that up.
Great. Thank you very much, Lillian.
Wonderful. Thank you guys so much.